It is great to be able to participate in this. I want to salute once again Lynn Fisher and Margot Nishimura for having come to this really great array of events and series, and it's our pleasure to join not only with the Department of History but with the School of Public Health in bringing Professor Charles Rosenberg here this evening, and I'd like to invite Fox Wetle up to introduce him to us. Fox.
Thank you. So Neil, I'm not so sure that you would want some of the cures over the ages, such as purging and bloodletting, so if they work, right. Thank you. On behalf of the School of Public Health, I want to thank the John Carter Brown Library for asking us to co-host this event as part of the 250th celebration. Today's lecture, Medicine in 1764, What It Was, Some Ways It Changed, and Where It Might Be Going, is directly relevant to public health. We are honored to have one of the foremost authorities on the history of medical science, Dr. Charles Rosenberg, here today. Dr. Rosenberg is a professor of the history of science and the Ernest E. Monrad Professor in the Social Sciences at Harvard University. He's written widely on the history of medicine and science and is best known for his books, for such books as Cholera Years, the United States in 1832, 1849, and 1866, or Expanding Epidemics, and Our Present Complaint, American Medicine Then and Now. He has co-authored or edited another half-dozen books and is currently at work on a history of conceptions of disease during the past 2 centuries. Professor Rosenberg is the recipient of several awards, including 2 Guggenheims, and the George Sarton Medal for Lifetime Achievement from the History of Science Society. He's an invited member of many societies, including the prestigious Institute of Medicine. I am very pleased to introduce Professor Charles Rosenberg.
Thank you very much for that gracious introduction, and thank everyone for coming on the, what's the word, the looming weather situation. And it's also an honor because it's not every year you have a 250th anniversary. There's something nice, symmetrical, quarter millennial about it, and it's. I always thought when we moved to Cambridge that Brown was a kind of neighbor, and as someone, I don't know why I'm throwing this in, but as someone who's been going to Cape Cod forever, I always felt that Providence was part of my catchment area, even if it was just meant driving through it. When I was asked to do this, I wasn't sure what was right. In the sense there were so many things one could say. But I thought what I would try to do is give a cross-section of what medicine was like in 1765 or 4, and then talk a little bit about the shifts that have created the world we live in now, and then end with a few comments about how labile our situation is now. There's a lot of things changing, and some of them are reminiscent in some ways of an earlier period. And so the first thing that I want to talk about is the problematic question of what's medicine. I think that most of us think about medicine as something that is defined with boundaries around it. It's what doctors do, it's what credentialed people do, it's what specialists do. It takes place, it takes place in a particular space, mostly hospitals over the past 2 centuries, outpatient departments. And I think we forget how historical that is, that in 1765, the world was very different. Now, maybe this is so obvious I don't need to say it, but logically, I need to say it. the great majority of the population in 1765, first of all, was rural, not urban. When we think about the development of medicine, we think of it in an urban context. We think of hospitals, universities, medical schools. We think of specialism. Those are all things connected with urban life. And less than 10% of the population was urban, less than 2,500. I mean, more than 2,500 people was the 1790 census definition for urban. And we also, many of us have a notion that there were doctors and surgeons and apothecaries, and they were all different and clearly defined. Even in England, that wasn't really true. But in this country, there were only a handful of credentialed doctors who'd studied in mostly Edinburgh in 1765, but only a handful of doctors, literally a handful, well, 10 or 15. There were many other practitioners, but they were a very diffuse group, and medicine was very diffuse. The great majority of practice, when you define it not as what doctors do, but what happens when people feel sick, is a very different focus. The great majority of medicine was done by people with no credentials at all. Midwives, mothers, grandmothers, people who'd maybe had an apprenticeship with a doctor. Maybe they'd been an apprentice with an English doctor who'd been a military surgeon or maritime surgeon. But the great majority of medical practice was domestic, and as I always say to students, did I do something wrong? I'm talking down to the audience, up to the audience? People were born and died in the same place that they ate and fought with their wife and raised their children and knitted. And so I think that's, and maybe it's obvious, it's not counterintuitive, but we tend to think when we think about medical history about that trajectory of how did we get to where we are. And so this is background noise to that history. But if you think about it from a, call it an ethnographic point of view, or from an experiential point of view, that's what was going on. The other point that I want to make is that if you look carefully, you can find a few traces of the history that was going to come. Coincidentally, the first medical school was 1765 in Philadelphia. Its major advocate was John Morgan, who wrote this discourse on medical education. And it's a very interesting, I went back and read this. I hadn't read it for many years. And it's quite interesting because in some ways it foretells the future, because it's based on the notion of linking hospital teaching, medical education, you know, with professorial, with the university. That nexus seems to us foretelling the future. On the other hand, if you actually read his discourse, it is primarily a defense of the traditional distinction between physicians and surgeons and apothecaries. And so he is defending a much more traditional notion of what a doctor is and what a doctor should be. And it's based on learning, not on laboratories, not on pathological anatomies, not on dissection. And the text is peppered with gratuitous Latin quotes and French quotes, and it's quite, I forgot all that. So again, this was a moment of change, and it's also a moment when America was very self-consciously provincial, but at the same time part of a larger world. And I think you can see this even in terms of notions about therapeutics. And maybe I'm coming at this in a complicated way, but if you try to reconstruct what people did when they got sick, well, some of it is invisible because poor people didn't keep records. But we do have some records. We have recipe books kept by mostly women. And what's striking is how recipes for food and recipes for healing are mixed in, and often veterinary things too. So you can see how life was textured, and that medicine was part of a larger life. And we have almanacs. We have popular books that are essentially recipe collections. I'm sure that the John Carter Brown has some of these, Medicine for Every Man His Own Doctor, which are largely collections of, if you get this, take that. You know, there's no theory. But one thing that struck me, again, when I went back and read some of these books, is how there is a vernacular herbal tradition that was obviously passed on from mother to daughter, father to son. But then it's also a part of the larger international world of medicine. Because, for example, if you look, maybe the most famous book is John Wesley's Primitive Physic. John Wesley, the founder of Methodism, wrote a popular health book. And it calls not only for simple herbs that anyone can gather and macerate and boil and take or rub on or whatever, but it also calls for antimony compounds, mercury compounds, jalap, which was a root from Latin America. So medicine, the ideas of medicine, and also these commodities were already part of an international world of trade. The ideas as well as the things. And I think that struck me, and I hadn't thought about that till I was thinking about this lecture. Let me switch to another aspect of the reality of medicine, and that is disease. What is disease? How is it defined? How is it studied? How is it understood? And I think the first thing to keep in mind is that our repertoire of specific diseases does not track onto their notion of what a disease was. There are some things, when they say smallpox in a text, you know what they're probably talking about, smallpox. But when they talk about something like flux or nervous fever or fits, well, it doesn't track so well. But I think the thing to keep, and I'm going to give you some examples from some bills of mortality from 1765. But I think one thing that we have to remember, that they are responding to what they saw and what they experienced and what they had to respond to. And even if those things don't make a lot of sense to us, that's what they were responding to. For example, and I took note of this because I referred before to John Wesley's Primitive Physic, which has a list of things to treat. Well, if you look under cough, he has recipes for a cough, and then an asthmatic cough, a consumptive cough, an inveterate cough, a convulsive cough, a pleuritic cough, a tickling cough, violent coughing from a sharp and thin room cough. He also has chin cough or whooping cough. So if you were a pediatrician, you'd say, they knew about whooping cough. But then you say, what's all that other stuff? Now, my point is that it meant something to him, and it meant something to his contemporaries. It's hard for us to reconstruct. But remember, they didn't have clinical laboratories. They didn't have thermometers. They mostly, even doctors, examined people with their clothes on. So that what they were responding to was the sensory input that they had and the categories they could put that sensory input into. And that's one reason why things like diarrhea, copious urination, a fevered appearance, hotness, if your tongue was white and not normal. Those were things that people could see and respond to. So that much of medicine was a response to these categories that grew out of what you could garner from a sick person's presentation, you might call it. Now, I know, again, this seems sort of maybe obvious, but it's important because I think you have to put yourself back in their frame of reference and not say, oh, how did they miss that? And let me give you this. I was very struck. I went back and tried to find some bills of mortality that were concrete. And the best ones that I found were from the Episcopal parishes in Philadelphia in 1764-65, because they provide causes of death and ages. And I'm going to give a couple of examples because I think it'll make it concrete. In 1764, these two parishes had 142 deaths. 56 of them were 5 years and under, and only 32 were above the age of 50. So that is more like Bangladesh 20 years ago. I mean, I hope no one's studying Bangladesh. But the largest category of diagnoses was something called decay. And that's nonspecific. Presumably, it's some kind of chronic disease, old age. Though old age is a separate category. But they have something called ulcerous sore throat, which I assume is diphtheria. You know, to make sense out of it from my 2015 perspective. And then 13 deaths were from vomiting and purging. Well, that's probably infantile diarrheas. We don't have seasonal data, but my guess is those are young children. And I can give some other. Fits is another one. 14 people died of fits. I think probably some of those are young children with electrolyte imbalance. Now the next year, 1765, there were 182 deaths in these two parishes. 93 were under 5 years old. 21 were above 50. But this year, there were 57 smallpox deaths. Previous year, there were no smallpox deaths. The vomiting and purging were 25. So you can make of that what you feel appropriate. Then they have fevers and nervous fevers. Well, we could talk about that. The point that I have some other years here, but what I want to emphasize is first the attempt by local people to track the data. This is before there were national. We didn't have national statistics on a lot of these things till the 20th century, actually. But there was a feeling that you should track the data to see what we would call them trends were. And there were some the churches kept their own records. The Baptists had their bills of mortality. But I think that, again, you can say this is like Janus-like. It's looking backward in the sense of disease categories that made sense to them, that mirrored you might call it the ecology of disease, but don't fit neatly in our categories. On the other hand, in some ways, it's modern because they are trying to keep track of the diagnoses, the age groups. They don't have it by age, but they have under 1, under 3, under 5, 50 to 60, and that's when I sort of added those up. So again, it's a very labile kind of moment. The other set of categories I think that were problematic for them, that were natural categories. One was chronic versus acute disease. That was very important. and for reasons that are pretty obvious. And acute diseases were the ones that were often epidemic. I didn't mention that tuberculosis, the single diagnosis that was most constant from year to year was consumption. Very stable every year. It wasn't like diphtheria or smallpox that was cyclical or in and out. The other category which overlaps a little bit is endemic versus epidemic. They knew perfectly well there were some things that they had always with them, like consumption, like decay. People got old, they got feeble, and they died. And that was a meaningful category. I know it sounds almost silly to say it, but it was data. I think we would go back and say, well, what did they think about contagion? What did they think about some of the issues that look important from the perspective of how did they get to be modern? And I think the one thing that I want to emphasize is that mostly they didn't think about contagion. There were some instances where contagion seemed both obvious and accepted. One was smallpox, because remember, they had been inoculating people since the 1720s, so they knew that there was a substance that you could pass that was a material substance from the arm of one person to the arm of another person and spread the disease. Another example, I don't want to shock anyone, was venereal disease. They also were skin conditions. They also knew that there was a mode of transmission. I don't want to be too genteel here, but I don't need to explain it. But those diseases seemed atypical. They got put into their, I don't know why it does that, but they got put into its own little box of atypical diseases. Most ailments were seen in a much more, we might say, holistic, multi-causal way. And the causes, again, are ones that we might, I think, when you start thinking about it, make sense to us. One is constitutional, especially in chronic disease. You weren't born with tuberculosis, but you were born with a tendency to it. Am I doing something wrong?
Push it this way.
A little this way. I'm too close?
I think that'll help.
Yeah, well, my mind wanders, so it's hard to keep a stable relationship with the technology, spatial or otherwise. And they also felt that your body was always, and I mean, I've written about this elsewhere, I don't want to, but that your body was always becoming. Remember, your health depended on what you ate, what your environment was, how you worked, how much sleep you got, even how much stress you felt. They didn't use the word stress. So that the models of chronic disease were all multi-causal and individual, as opposed to the specific disease being imposed upon a person. And it's not surprising that they felt, well, a cold could turn into pneumonia, pneumonia could turn into consumption. That you were always on a potential slippery slope. And that's why a lot of the popular health writing, not for ordinary people who were not too well educated, but for educated people, were about regimen, were about what you should eat, what exercise you should get, how long you should sleep, whether you should bathe regularly, and in a sense controlling that slippery slope, controlling your body as it changed from day to day, as it turned into, it always had to reconstitute itself. And that was their key model of chronic disease pathology. So it was a mixture of individual cards you were dealt at birth, and then how you played the cards, so to speak. And not everyone had the same cards. They all knew that poor people didn't have the same choices. They all knew that poor people couldn't decide to go on a cruise to the Caribbean or even change their diet. So that was understood. But what I want to do is emphasize the way in which the individual equation was the key way of thinking about disease, and not about contagion or a contagious agent, and that disease was protean and could change its form and move from one form to another. Well, all this was about to change, as we know. In the 19th century, and this would be a whole course, which I'm going to do in about a minute and a half. In the 19th century, medicine got more spatially divided. The hospital became more important. Outpatient programs became more important. Medicine became more specialized. You began to have the beginnings of specialty organ training, specialty training within hospitals, and specialty practices outside. You began to get licensing, credentialing, and all the things that we associate with the modern world. And of course, the model of disease began to change, so that infectious disease, especially beginning in, as you probably all know, in the 1860s and 70s, began to shift to a model of something outside the body that could get into the body and cause certain pathological changes that were predictable and reproducible. You know, the germ theory, I'm trying to avoid saying germ theory. And with that, of course, came the whole, what we would now call the biomedical complex, I guess, is the way of describing it. The application of basic medical sciences, physiology, biochemistry, et cetera, to medical problems, the institutionalization of the laboratory as a part of the diagnostic and therapeutic regimen in medicine. Now, obviously, this was gradual. It was urban. I mean, all these tendencies were obviously most intense in the biggest cities, where there was an infrastructure where elite physicians could create their infrastructure, where they could be hospital physicians, where they could be medical professors, where they could have practices that catered to wealthy paying patients and non-paying charity patients. Sorry, I keep doing that. I think this is all stuff we sort of take for granted. And in the 20th century, it's become even more, what's the word, intense. All those trends that were apparent at the turn of the century, 1900, 1910, hypertrophied, metastasized, maybe that's the right word. But the tendencies were already there. I was very struck when years ago when I was working on hospitals, how people began in the era of World War I to start saying, we're treating a disease and not the patient. That we're turning people into bureaucratic categories. We're imposing protocols on patients. We're forgetting about families. We're forgetting, and we're, for example, that's a period when medical social work got started, because there was a concern that you can't take the person out of the community, out of their family structure, treat them, and then just release them back into the community without any continuity. You might call it the social medicine tradition. So that existed, but was always oppositional. Oppositional in the sense that it was a minority position as opposed to the growing power, both in terms of social influence and also predictive capacity of the laboratory sciences. And, well, here we are. And I wanted to take a little time to talk about, well, I wrote a piece called Back to the Future, and I've been thinking about this for a while. And there are ways, we're not going back to 1765, but there are ways in which the bureaucratic, spatially located, highly technical world of medicine, the boundaries of that are becoming more diffuse. The boundaries are softening, and in part there's a kind of dialectic. It's a consequence of technology too. We have telemedicine. You can use your iPhone to be your ophthalmoscope and your otoscope. We have technology to remotely, you could take a drop of blood, put it in a, I don't know how the machine works, but it can tell you what your clotting time is or what your blood sugar level is, and send it to a clinical facility. So things that had been spatially located and bounded by hospitals and by specialized laboratories is now being diffused. I think it's happening also in terms of credentials and who can do what to whom. Some of you have probably walked into CVS or Walmart. No one here goes to Walmart, presumably, but Walgreens. We don't even have a Walmart in Boston, but you have these outpatient clinics in effect. CVS has what they call minute clinics. There was just an article in Time magazine about them, which are mostly staffed by nurse practitioners. But in many places, the nurse practitioners are hooked up with attending physicians in hospitals, so that the physical boundary, the space of the hospital is being redefined. And partially there are policy issues and economic issues that affect this, as we all know. But partially it is a consequence, as you know, of a changing technology that makes the diffusion of medical services more possible. I just came across just the other day, a website or organization called healthtap.com. Does anyone know this? It says, where is it? I wrote down their motto. Oh, it's a private doctor anywhere you want to be, video or chat 24/7. In other words, you can sign up. They allege they have 65,000 doctors. What this means, I don't know. And you can sign up for an individual doctor or for general service. And if you have an earache or you have, I don't know, angst or something, you can either go on the internet or actually have a visual, Skype-like intercourse with this doctor. Now, I'm not saying it's the same, but I'm saying that the technology has made things fuzzier. The boundaries are not as distinct. And I think there's also been a set of debates that are more theoretical. On the one hand, I would call them from the social medicine perspective, thinking about disease in a reductionist, mechanism-oriented way is not enough, that we have to think about things like, let's call them larger ecological, environmental factors that create patterns of morbidity and mortality, that it isn't just Bangladesh or Sierra Leone, but Providence and Boston too. So that's one kind of critique. And the other is the other end of individual genetic medicine, which says the solution to our problems, it's what I call the N of one problem, that everyone is a little different, and categories and protocols and best practice guidelines don't always work for particular patients. Well, the way you solve that is to get even more reductionist and have a genetic picture for each individual to see how a drug acts or why their protein synthesis is screwed up and they're going to get particular kind of metabolic disease or cancer or something. So we're living in these, a period of instability, I guess you might call it. And it's also mirrored, as I've implied, at the policy level. How do you pay for it? What kind of research gets supported? What kind of training gets supported? And it seems to be all up in the air right now. And maybe that's a good thing. I think I'm going to stop. I don't know whether I was supposed to have questions. I'm so used to answering questions. But so I'm be happy to do that. And I'm sorry if I try to cover too much in too synoptic a way, and also the sound effects. But yeah,
was there any evidence in your research of mental health diagnoses in the 1700s?
Well, the category mental health diagnosis is a tricky one because it implies a distinction between mental and physical, which I think wouldn't have been very meaningful to them. Partly because of notions about everyone having a kind of humoral makeup that affected their passions, perceptions, responses to the world. And there was a notion of you might call it depression, for example, melancholy, and there were and they knew that there were some people who were crazy, who voices talk to them and things. But, in terms of mood disorders, they'd have to be pretty extreme to be seen and if that case, they were always necessarily seen as material. Material in the sense of coming out of a basis that's physiological. If that, yeah.
I have two questions. One had to do with your discussion of, I'm trying to understand what they mean when they talk about a particular problem. And the other one, more a geographic one. The geographic one first. When did the practice of ghettoizing people who travel in lazaretti, when did that start?
Well, quarantine goes back to the 14th century. How well they did it is another question. In fact, there's a professor at the University of Pennsylvania right now writing a book about how well the lazaretto quarantine system worked from the late 18th century on. But there are many ways in which it was a permeable system, and up through the mid-19th century, it often was only in response to perceived epidemic situations. So it wasn't systematic. That's all it's complicated because different places had different histories.
The other question was plague. Plague in the Eastern Mediterranean. You read travelers, you read people who are living in this area, and they're talking about plague. What exactly would that mean?
Well, when they say plague, they probably meant, they almost certainly meant bubonic plague. But bubonic plague was never a big deal in the United States. There were panics about it. At the turn of the 20th century in San Francisco, there was a plague panic, you might say, and in Honolulu, as sort of the edge of a pandemic of bubonic plague. But plague is a generic term, but it's also a specific term. It's generic in that it's used to say the plague of cholera or plague of drunk driving or whatever. But it also meant a specific bacterial disease that is spread by rat fleas, or now they think gerbil fleas, I heard on the radio the other day. Who knew? Yeah.
I have a sort of related question. We know now, we feel now that so much of what we teach our medical students will be proved wrong in a year or two, and so much of what we taught them 10 years ago was indeed proved dramatically wrong within a few years. When do you think this sort of doubt started to arise in the system? I have a feeling from what you said that back in 1765, there was the concept of tradition, whatever you taught, would remain to be true for the next 10 or 20 years.
That's a good question. I think if you took a physician in 1765, I bet you most of them would say, we don't know exactly, we know certain things. I think many physicians today would say the same thing. They'd make a distinction between things they would say, there are things we believe that I know we will believe 50 years from now. Then there are things that are subject to revision. And I think that I've been struck talking to older physicians. I don't know what older means. As I've gotten older, that definition seems to redefine itself. But physicians who did their training in the 50s and 60s, and how struck they are by the point, I think that things that they were learned as residents and house officers, how could, but they don't see that, they see that as a positive thing somehow. They say, look at where we've come in my own lifetime. And I can't tell you how many people I've said, I'm summarizing what a lot of people have said in different words, but I would say that's the bottom line. So that it's a mixture of a tentative sense that we're contingent, but a piece of our world isn't contingent. If that, yeah.
At what point did the term, the title doctor, become associated primarily with medical personnel?
In this country?
Yes.
Late 19th century. And of course, then there's the trivial question of licensing and the formal bureaucratic piece of it, because a lot of people, of course, said they were doctors who weren't. And so there's a whole apparatus of testing and diplomas and accrediting schools. I mean, it's hard to take it out of that bureaucratic context. Yeah.
We've heard a number of talks here by fellows who are working on Europeans adopting or being intrigued by indigenous, what do you do when people get sick, practices in the Americas. And I'm wondering if you see in North America some crossing over and adoption of remedies and ways of thinking from either Native Americans or from Africa in the 18th century I'm talking about.
It's a good question. I was some graduate students asked me that earlier in the day. There are examples of, you might call them direct, maybe the most prominent is quina, which is from South America, and it was widely used for, often used in a non-specific way, though we think of it as having a specific effect in malaria. And there are other drugs like that I mentioned, Jalop, Ipecac, and there is a kind of traditional history of ideas thing about a remedy for a disease being found in the place where the disease is found. And so there's a certain amount of romantic, well, maybe that's not the right word, but it's kind of a cultural aura surrounding certain Native American, South American, or African practices. But I think when you add it all up, it doesn't amount to that much. I mean, it sounds, and I was also as I said, came up earlier in conversation, there was invocation of the authenticity of Native American practices. As I mentioned, the Thomsonian doctors, the botanic doctors in the early part of the 19th century said these herbs are effective because we learned them from Native Americans. These were indigenous to this area, and they're effective. You know, these 6 drugs. And they also used steam tents, you know, where they steam people. And they said that this is a Native American thing. And then there was the use of invocations, I call them, of Native American and patent medicines. But I don't know, when you add it all up, I don't know what it adds up to. No, I mean, but it's not I'm just talking off the, you know, I've never systematically studied this.
I think we have time for one more question, if you will. I wanted to give to Eve Ornstedt, who is the coordinator of the 250th anniversary.
She gets two questions.
So the question I had is because we've been talking so much of the role of the Baptists and other religious communities in the establishment of institutions of higher education in the late 1700s, how those religious communities played a role in founding of perhaps more formalized healthcare delivery systems throughout in the urban areas or within the establishment of the United States.
They did. And some of it was defensive. Many of the Catholic nursing orders, for example, staffed hospitals that were established because Catholics weren't treated very well in Protestant hospitals. And there were ethnic versions of this. You go to Minneapolis, and there's Swedish hospital, and Jewish doctors weren't allowed in the mid-19th century, given hospital appointments as attending physicians. That's one of the reasons that German hospital in Philadelphia and well, it used to be German hospital in New York, but these were Mount Sinai was like that too. I mean, these were, you might say, ethnic responses to social structure and to social prejudice. And then, of course, the nursing orders, Episcopal and Catholic, had a huge role, especially as you move into the Midwest. Often the only hospital in a growing city was a Catholic hospital.
Before we thank Professor Rosenberg, I wanted to plug 2 things. The first is the final lecture in the 1764 series, which will be given by our own Gordon Wood, I believe on, I want to say May 17th, but it may be 21st. 23rd. Or maybe the 23rd. Let's go with the 23rd. I think that's a smart idea. We very much look forward. That will most likely be here at the JCB, again, to cap off what has really been a phenomenal series. So thanks again.
It was snow be melted by
if it ain't, I'm moving back to California. The other plug that I would like to put in is that the curators here at the library, Dennis Landis and Ken Ward, have put together a mini exhibit of some materials from the collection related to medicine and health in and around 1764. So please take a look at that. Get a glass of wine. Please don't spill it on the glass case. And please join me in thanking Professor Rosenberg.